everybody. Thank you for joining us. Dr. Guy and I are going to talk to you a little bit about TMS. And he's going to go first, and he's going to talk to you about the procedure, what it looks like, and who would be appropriate patients for you to refer. And then I'm going to come in at the end and tell you a little bit about what my role is as a TMS coordinator. I'm sorry, my name is Lindy Bostek here, and I'm usually in Troy. I'll tell you how you can make a referral and how I can help you, and I'll give you my contact information. And then we're going to open it up to some questions for Dr. Guy, okay? So this is Dr. Guy, and here we go.
All right, well, thank you, Lindy. Welcome, everybody. I presume most of you saw my previous program on TMS, so I don't have to repeat all that stuff. I'm going to refresh your memory on a little bit of it, but we're not going to go over the whole thing. Today, as Lindy mentioned there, we're going to talk about patient selection and preparation. Who makes a good candidate for TMS, and what do I need from them? I make several recommendations for the patient just during the procedure and prior to entering the procedure. So hopefully that'll give you guys an idea when the patients are discussing what I talked about with them. You'll know what they're talking about, because especially with regard to things like the supplements that I recommend and the drugs that I recommend that they come off if they're going to be going through TMS. Alrighty. So let's get started. First of all, transcranial magnetic stimulation is approved for several things now, and that list will be growing in the future. Okay, so right now, as you're probably aware, we principally do it almost exclusively for major depressive episodes. It is approved for major depressive episodes for unipolar depression. It is also approved for bipolar depression. It's also approved for obsessive-compulsive disorder. Now, the machine that we have here in Troy right now is not approved for OCD. Obsessive-compulsive disorder requires something called deep TMS. And there are several machines. There's one machine right now, the BrainsWay machine, that is approved for deep TMS so that it can handle obsessive compulsive disorder. But there is another machine that's about to be approved for that purpose as well. And we are going to be acquiring one of those machines. And so in the future, we will be doing obsessive compulsive disorder as well. Okay? So, who is a candidate for TMS? When you're dealing with a patient who mostly has severe depression, how can you tell which severely depressed patients are candidates for TMS referral? All right, well, what does it take to be a candidate? Well, number one, they need to be in a severe depressive episode. Mild depression doesn't cut it. Moderate depression, for most insurances, that doesn't cut it, because essentially this is who puts the restrictions on us. It's the insurance companies. Now, if they have Medicare, the restrictions are actually the least restrictive of all of them, if it has Medicare. But for insurances, they have quite a few things that they demand. For one thing, their depressive episode needs to be severe. So if you're scoring them with the Hamilton Depression Rating Scale, then their score needs to be 19 or above. So they need to score in the severe depressed range. And right now, the way it is, the overwhelming majority of the patients that you guys send to me, they all meet that criteria. So you're doing a great job in picking them out. They very rarely do I have a patient that's sent to me that doesn't have a HAM-D of at least 19. All right? Or if a PHQ-9 is used, then you want that score to be 20 or above. So essentially, they need to score in the severe depressive range. Now, next, they need to have failed on more than one antidepressant. Most insurances want that to be like 3. Some will settle for 2. Okay? But they need to have failed. So you've tried them on an antidepressant, and of course, if they didn't get a response or had an incomplete response, then you need to bump the dose up to the high dose so that they're not taking the introductory dose. So you need to have tried them on a decent dose for a good enough time, So they need to have been on these medicines for a month or more usually, okay, before you give up on these drugs. So they need to have failed on several antidepressants. Now, with most insurances, that's not enough right there. Just because they fail on a couple of antidepressants You're not a candidate until you also fail on at least one augmentation strategy. And the one they recognize most readily is the strategy where you add an atypical antipsychotic to their antidepressant, because we have double-blind placebo-controlled trials showing that this is effective. It actually gives you extra oomph. It causes the SSRI to work better, if you will. So the atypicals most readily recognized for depression augmentation are aripiprazole or Abilify. And then there's Rexulti, which is essentially new and improved Abilify, okay? And the first atypical that was approved for this purpose was Seroquel XR. So those are your three primary augmentation strategies. So severe enough depression, they have failed on 2 or 3 antidepressants plus at least one augmentation strategy. Okay, so with regard to pleasing the insurance companies, those are our big guys. So before you send us patients, take a look at the record and see if they meet these criteria. All right. Now, I have my criteria, and if you take a look at clinical trials, you'll see that, well, most people respond to TMS, and some people have remission. Some people have, a good number of them experience at least a 50% reduction in their depression rating scales. That's true. Now, my results are significantly higher. In our clinic, we have well over an 80% response rate and a remission rate that is very much higher than what the clinical trials show. Remission is a HAM-D score of 7 or below, where their symptoms are completely resolved. Ours is way higher than what you see in the literature, and partly that's because we're picky. I don't bring people into the program that I'm confident that they won't do well. I've been doing this since 2013, and so next year this will be 10 years. And during that time, I got a feel for the people that respond well to TMS and those that don't respond well. And so what I try to do now is exclude those people at the beginning who aren't going to do well with TMS. As a result, the people that do get let into the program tend to do really, really good, because we've gotten rid of those patients who are unlikely to respond to TMS. Now, the first one in red, not actively suicidal. Well, here's the deal. When you're doing TMS, you're attracting the worst of the worst. These are patients that other psychiatrists have given up on. These are people usually that have been getting treatment for some time with very little benefit from therapy, from medications. Okay. Oh, that's the other thing. They need to have been in therapy. I didn't mention that. So that would be the first 4. Okay. So I forgot that one. So they need to have at least one significant therapeutic intervention with psychotherapy. Okay. Now, the suicidal thing, as I mentioned, we attract the worst of the worst. And so you're going to get some people who are so depressed they're suicidal. If they are actively suicidal or have had suicide attempts in the last year, I will now refer them to ECT. Okay? And that's because if anything happens, and I've had a couple suicides since I've been doing this in the last 9 years. If that happens, and there is litigation, they're going to say, well, you knew they were suicidal. Why didn't you think about ECT first? Okay. ECT is kind of still the gold standard. Now, in clinical trials, ECT and TMS, electroshock therapy and transcranial magnetic stimulation, are very similar in that both are causing electricity to move through your brain circuits, through the different pathways, and both have similar effects on your brain. ECT is more aggressive, obviously, and when you have somebody that's suicidal, ECT is faster. I mean, regardless of ECT does work more quickly. There are some downsides to ECT, but the benefit is it works rapidly. You can't drive yourself to your ECT treatments and then drive yourself home. You require another person to be involved with you pretty intimately, and so forth. And also there's sometimes memory difficulties with ECT. So there's quite a few things. But when they're suicidal, ECT is your best bet. For one thing, and not just for the legal stuff, but with ECT, you want them to get better fast because you want to get them as far from suicidal thinking as possible. So ECT would be my recommendation. Now, if they had suicide attempts back when they were children, when they were teenagers, and they're now in their 40s, I wouldn't worry about it so much. If they've had nothing since then, but if they're really, really suicidal, then I would say go with ECT. All right, now the next one, not taking over 1 milligram per day of a benzodiazepine. Ativan, Xanax, Klonopin, one of the sleeping pills like Restoril, Valium. No, 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 no. These agents, for one, double your risk of dementia, so I'm not too crazy about using these on a regular basis. They are depressogenic. So while they help with anxiety, they contribute to depression. Okay? Very often, if you look back on patients that you might have known that have committed suicide, very commonly, what contributes to suicide? Alcohol and benzodiazepines. These are both very depressogenic. Okay? So if somebody comes in and they're taking, 1 milligram of Klonopin twice a day, no. 1 milligram of Xanax twice a day. No. 1 milligram of Ativan 3 times a day. No, 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 no. Clinical trials show that with transcranial magnetic stimulation, these patients don't do very well. And it makes sense. What we're doing with TMS is we are increasing brain electricity. We are increasing electricity through critical brain circuits, especially that circuit called the central executive network. When you're taking benzodiazepines, you are doing the opposite all throughout your brain. You are suppressing electricity. Therefore, you are suppressing the release of brain-derived neurotrophic factor, and therefore you are suppressing synaptogenesis and neurogenesis. You're suppressing the evolution of new brain connections, and you are suppressing mitosis of the neurons. So that's the opposite of what I'm trying to do with TMS. So that's why if somebody comes in and they're taking more than a milligram of benzo, I don't like any benzo, to be honest. I mean, I tell the patient it would be better if they were on none. But I will accept, in a pinch, I will accept 1 milligram a day. But keep in mind, any benzodiazepine is going to impair the efficacy of TMS. But I have seen people respond if they're on 1 milligram or less. But over a milligram, it's highly unlikely that you're going to get anything out of this. Okay? Next one, not active substance abuser. Substances of abuse are depressogenic. In the long run, they promote depression. Things like alcohol, benzodiazepines, they suppress brain electricity. Now cocaine doesn't, but that's another story. No, you don't. That means your mood is going to be horrific if you're in the middle of a substance abuse binge, and that's a habit that you've had for some time. If you're spending a bunch of money on cocaine, heroin, even marijuana. No. Marijuana is not. Oh, that's a whole other talk, and some of you heard that talk. But no, if you're actively using, I warn them that this is adversely impacting their mood, and I usually will refuse to do TMS because outcome's just not very good. Now, with regard to marijuana, if they say, well, I take maybe 1 puff a month. Yeah, sure you do. Okay, they might be telling the truth. If you know the patient and you believe they're telling the truth, then okay, all right, I don't like it, but that's not terrible because it is dose related. But if there's any chance that they're minimizing their usage, then I don't want to waste their time. What's happening when you're using marijuana is that it increases dopamine throughout the brain, including dopamine in emotion circuits such as the amygdala and associative striatum. And when you increase dopamine in those areas, that's going to increase negative emotion. And we're trying to do the opposite of that. So the likelihood of TMS, again, being very effective is less. Okay. Plus, THC is neurodegenerative. I'm trying to do the opposite. We're doing TMS to increase brain-derived neurotrophic factor so that we can improve the health of your overall brain, and you're taking something that is having the opposite effect. So, last one. Not in the middle of a disaster such as divorce, death of a loved one, foreclosure, an impending prison sentence. I've seen these over the years, and people who are in the middle of something really horrific, guess what? They don't get better, because the reason that they're in this horrific depressive episode is because of a situation that's still going on. Their spouse has still left. Their child is still going to prison. Their relative is still sick, or they have a terminal illness or something. And so, yeah, if they're going through something that is clearly the obvious reason for their depression, getting your brain zapped does not make that go away. Okay, so what we're doing with TMS is we are helping the brain to function more optimally, but optimal brain function doesn't make stressful circumstances go away. It doesn't put money in the bank. If you're facing foreclosure or bankruptcy, going through a $5,000 procedure is not going to change that. Okay, it's just going to take more money away, especially if you're paying cash. So, and these are not cases that I'm likely to accept, because the likelihood of getting better just isn't that good. So those are some criteria for candidacy for getting TMS. Now, I mentioned that ECT is something that I would choose if they were suicidal. Now, TMS does have some advantages over ECT. There's no seizure necessary in electroconvulsive therapy or generating a seizure. It doesn't require an anesthesiologist to be standing there. With ECT, an anesthesiologist is part of the program, okay, because the people aren't awake when their brains are being zapped with electroconvulsive therapy, okay? There's no cognitive disruption. If somebody has very severe depression, they will often use bilateral leads. So not just one lead on one side of the brain, but bilateral leads. Bilateral leads are much stronger for more resistant depression, but it can cause pretty significant memory loss. If they have to do bilateral leads, I've seen situations where people have forgotten their marriages, they've forgotten the birth of all their children, no memory whatsoever, as though it didn't happen. They search and search, and they, for the life of them, don't remember moving into their house or getting married or having kids. I mean, that it can do that much damage, okay? And so also the subjects remain independent. In TMS, they drive themselves to and from their appointments. There's no memory lapse, no loss of awareness. But with ECT, somebody has to drive them to and from their appointments because they can't be trusted for that, because it has such a profound effect on the brain. Okay? So those are some advantages to TMS over ECT. Now, what are some contraindications? I recommend that last list that I gave you were relative contraindications, and some of the things that if you follow those rules, it is likely that your patient is going to do better with TMS. There are some contraindications. If anybody has, and the first thing I ask them when they come in for their first appointment is, do you have any metal in your head from the neck up? That's it. And that's something you can ask patients. If you're thinking about referring them for ECT, or for TMS, ask them, do you have any metal in your head from the neck up? Okay? That means aneurysm clips, like, for example, if they had an aneurysm at one time, or if they had brain surgery, were they in the military, they have a piece of a grenade sitting up there, okay? They have a bullet in there somewhere, all right? So you want to know that. Any conductive, ferromagnetic, or other magnetic sensitive materials that are implanted or are non-removable, and that's, again, from the neck up, all right? If they had a bunch of face piercings, those can be taken out. And what happens if you don't take out all these piercings and the tongue metal and all that kind of stuff, it will heat up. That's the danger, is that it will heat up and get really hot during the procedure, okay? So we don't want that to happen. We don't want to have a barbecue when we try to do TMS on somebody, right? Okay? So we want to know, do you have any non-removable metal from the neck up? All right. So that's kind of those are kind of what our recommendations are and our restrictions are with regard to TMS for patients with anything. That includes depression, whether it's bipolar depression, unipolar depression, or OCD. Those are some general commands, general recommendations, and those are what we need to see in order to pick when we're selecting a candidate. Those are some of the guidelines that we need to follow. Now, it is now approved, as I mentioned, for obsessive compulsive disorder. Obsessive compulsive disorder is a really terrible malady. In psychiatry, there are a couple of diagnoses that are the worst. And what I mean by the worst is not the worst in terms of effects on cognition and stuff like that, but they are the worst in terms of our medicine doesn't help that much. That in spite of our best therapies today, people remain grossly symptomatic, and our medicine only does a little, but these people remain largely symptomatic. And I'm not talking about schizophrenia or schizoaffective or bipolar. No, no, no. We've actually made a lot of progress in those areas. With regard to for most psychotic illnesses, we've made so much progress that it's not unusual to have somebody who has one of these illnesses and nobody knows it. They're maintaining a job. They seem to interact socially in a way that they're doing okay. So, I mean, we've made tremendous progress in these areas. However, there are two maladies that we still have a long way to go in. One is obsessive compulsive disorder. I've had friends who developed obsessive compulsive disorder. The last one that did it was after the birth of her second child. She was a social worker, and her OCD symptoms were so bad she had to quit work, and she's not worked again in over 20 years because she can't get out of the house. She's too busy washing clothes and washing her hands over and over again. Utter misery, utter misery. It's a terrible thing. And she's had all these different medicines, everything that's FDA approved, she's had it all. And nothing has made a serious dent in her habit. She can't stop doing this. So it was really very, very devastating. It just really messed her up. The other disease in psychiatry that's very difficult to treat is delusional disorder. When people have a fixed false belief. My first case of delusional disorder was a guy who believed that the people of the country of India were taking over the United States by pretending to be psychiatrists and locking Americans up indiscriminately. So that was a thing, and this person believed that with their heart, mind, and soul. They really believed that that was the case. I had another guy who believed that the Truman Show was true, that he was, remember Jim Carrey, that movie he was in called The Truman Show, where everybody in the world was watching his life. From the time he was born until the present time, his life was a TV show, and people were watching him everywhere he went. He was utterly convinced that his life was like The Truman Show, that people were watching him. And when he finally came in to get help, he said basically he's just exhausted. He's tired of people watching him, and it's making him depressed that he has no privacy. In spite of pleas to take him off the air, he can still feel people watching him, and he wanted help with his depression because he was sick of people looking at him. And it's very difficult to get that to go away. In fact, to be honest, I have never gotten delusional disorder to go away. In 25 years, I have never had a case of delusional disorder where the delusions went away entirely. The best I did, I think Latuda was an agent that I used once on a guy, the Truman guy, to where he was still bothered by people watching him, but I mean it wasn't bothering him very much, and he was able to start work again. And so that was a big deal. That the belief, the obsession that people were looking at him became lowered enough to where he didn't feel as distressed by the malady. He still had the belief, but we just lowered his distress a little bit. That's what these disorders are like. So OCD and delusional disorder, very, very difficult to treat. So having this approved for OCD is a big deal. This is something besides psychotherapy, something besides pharmacotherapy that has been shown to be effective. And it's something we can use with other treatment modalities to further improve the quality of life for people who have this really debilitating illness. Okay? Now, one thing we know about obsessive compulsive disorder, if you know anything about functional neuroimaging, one of the things that we study in functional neuroimaging is functional connectivity. When people are doing certain things in their brain, like when they are going through an OCD moment, what circuits are active? And what we've discovered is that the default mode network is turned on in conjunction with the salience network, and they're turned on full blast. The salience network is the network that is active when you're deciding what is relevant to right now. What is relevant to your life right now? Like as I'm speaking to you, the garbage disposer is irrelevant. I shouldn't be having thoughts about the garbage disposer because it has nothing to do with what I'm doing right now. It is irrelevant. It is not salient. Washing my hands is irrelevant. Okay, there's nobody around. There are no significant germs that can do me physiologic harm or anything, so I shouldn't be thinking about those things. The salience network is the part of my brain that determines what is relevant now. What's relevant now is that I'm awake, that I'm speaking, that my voice isn't crackling, that the camera's working, that the software is up. Those are salient to right now. People with OCD, the salience network has gone insane. It is now working in conjunction with default mode, and default mode is the network that tells you, that compares you to yourself and to other people, and asks the question, is anything wrong right now? Am I measuring up? And so when you put those two together, you get OCD. And that's a problem because OCD is so difficult to treat. So TMS is now approved for the treatment of that. Okay? So, and just real briefly, I'm going to go into more OCD stuff in a minute, but I just want to mention that I discussed this last time, but I just want to refresh your memories that one of the things that we've learned is that when people fall into severe depression, the prefrontal cortex goes dark. What I mean is when you do functional neuroimaging, you look at glucose uptake and electrical activity of the various parts of your brain. And normally, in a happy, healthy individual, there is a certain amount of electricity in the front part of your brain, which demonstrates that you're using your logical brain. You're using your central executive network. It turns out the more you use your central executive network, the less depressed and anxious you are. It actually contributes to a healthy mood. But if you've been depressed day after day, week after week, then you get stuck in a rut, and your ability to turn on your central executive network is impaired. Medications just aren't working like they used to. Okay? So you bring in TMS, and what that does is it increases electric output in your logical brain. So you put it over the dorsolateral prefrontal cortex, and it feeds the entire prefrontal cortex. That's what happens when you turn on those magnetic pulses. That high frequency magnetic pulse generates electricity in the brain underneath, and that goes through and actually even affects some of those deep circuits. The bottom line is that by turning that on and generating that electricity, my central executive network is flipped back online, and functional MRI shows increased electricity in the logical brain. Now think about it. The logical brain, when you're facing problems, it's the logical brain that gives you mitigation strategies. It helps you figure out how to solve problems so that you're not so depressed about whatever's bothering you, because your logical brain is giving you solutions. All right? So the logical brain is responsible for executive functions, and those include planning, memory recall, organization, focus, strategy, and time management. Okay? Now, another thing that is askew when you are depressed is an overactive emotional brain. The amygdala, the associative striatum are hot. You see excess activity in this part of your brain. So what have people with depression have? Little activity in the prefrontal cortex and excess activity in the temporal lobe over there where your amygdala is, and your associative striatum in the middle part of your brains. And so those are the hallmarks of severe treatment-resistant depression. Okay? So when we give people therapy, when we do talk therapy, what you're doing is bolstering the logical brain. We're giving the logical brain ammunition, problem solving skills, so that it helps to turn the logical brain pink again. Because when you're doing functional neuroimaging, pink and red and yellow, those are colors of increased electricity. But blue and green, that's decreased electricity. So we want to turn the prefrontal cortex from blue to red. That's what we want to see. And that red in the prefrontal cortex is a sign of a healthy brain that is not going to be depressed. So talk therapy helps enhance the prefrontal cortex. It enhances the electricity there. Now, the amygdala is very hot, and we bring that down because we want to reduce the temperature in the amygdala. You want to reduce electricity flowing through the amygdala. When we give antidepressant medications, most of the time what we're doing is increasing serotonin. Increasing serotonin reduces stress hormones, and ultimately we are reducing the activity in the amygdala and associative striatum. So talk therapy does reduction of improvement of prefrontal cortical activity, and the medication reduces amygdala activity. Okay? Because what happens over time of depression day after day after day is that the density of the dendrites goes down. In our brains, as I mentioned before, you have about 100 billion neurons. Each neuron has little branches called synapses. And in a healthy brain, you have about 10,000 synapses per neuron. 10,000 per neuron. And as your depression goes away, as your depression ensues, as your depression goes up, you go from 10,000 synapses per neuron to around 5,000 or 4,000 synapses per neuron. The lower the synapse density, the more depressed you become. We know that for a fact. We can actually, there's a form of research involving nuclear medicine, or use a carbon-11 radio labeled tag to basically label SV2A, synaptic vesicle 2A, synaptic vessel glycoprotein 2A, and what that does is that tells you what your synapse density is. And so the higher your synapse density, the less your depression. And the lower your synapse density, the more the depression. So what we're doing with TMS is we are stimulating the development of new synapses. Okay? Now, what do you need? So think about that. And it's important to understand when you're thinking about referring a patient for TMS, I want you just to imagine what you want to do is physiologically change their brains. Now, we don't do this test, but if we were able to do this nuclear medicine test, if you have somebody that their Hamilton scores, let's say you got a 20 on the HAM-D, that's severely depressed, right? So you can imagine that patient's brain. If you look at this picture right here, look at the branching rectangles. The one at the top of the screen shows fewer branching. That's the brain of somebody who's stuck in a depressive episode and nothing is working. Okay? We want to get them to that bottom rectangle. We want to stimulate neurites development. We want to stimulate the expression of more dendrites. So, how do we do that? Well, think about it. The dendrites are made. Think of the dendrites like the arms of an octopus. Okay, in an octopus you have 8 legs. Now, in a brain cell, a healthy brain cell doesn't have 8 legs. It has about 10,000 legs. In order to make new legs, the legs are made out of skin. The legs are made out of the plasma membrane skin of the brain cell. So what is the skin made of? There are 4 fats that make up the plasma membrane of a brain cell. Those fats are, number 1, cholesterol. We'll get into that. I kind of got ahead of myself here. I need to back up a little bit. When I bring somebody into the TMS program and agree to do TMS on them, I always tell them there are some supplements that I very much want you to take. And there are reasons why you need these supplements. And so I want to explain that to you guys so that you'll understand what I'm telling the patients, and you can maybe even reinforce what I've said, okay? One thing I want is all my patients on omega-3 fatty acids, at least like 2,000 to 3,000 milligrams of omega-3s per day. Could be fish oil, Could be flaxseed oil, even krill oil. I don't care. But they need to be on omega-3 fatty acids. Now, not for the cardiovascular benefits so much, not for the arthritis benefits so much, not for the triglycerides benefits so much. I want you on them because it increases the production of serotonin. Sometimes the antidepressants weren't working because antidepressants block the destruction of serotonin. I need you to make more serotonin. I want your body to be optimized to make normal amounts of serotonin, because low serotonin is going to impair your ability to get better. So yes, at least 3,000 milligrams of omega-3s per day. Fish oil or flaxseed oil, I don't care. You need some omega-3s. Number 2, vitamin D3, from 1,000 to 3,000 units per day, depending on your skin color. Or actually 1,000 to 5,000. If you have skin the color of mine, then I would recommend 5,000 units a day. If you have light skin color, then maybe 1,000 or 2,000 units a day. But that's what vitamin D is necessary for 3 things. Number 1, your immune system. You need that vitamin D3 for the CD8 T cells, which are responsible. It helps prevent autoimmune disorders and viral infections. Vitamin D3 is necessary for bone health, for bone mineralization, which most of you probably know. It's also important for the central nervous system. That includes your brain and your peripheral nerves. So in order to have a healthy brain, you cannot be vitamin D deficient, okay, if you want to optimize brain health. So vitamin D is necessary. Now the next one is, I'm going to skip down to the 4th one here. Something to boost brain-derived neurotrophic factor levels. BDNF is a hormone produced by the glial cells. Those are the cells that help the neurons in your head. And BDNF is like a hormone that helps the brain cells increase the number of synapses. It also helps the brain cell live its full lifespan. So BDNF boosters are important. That includes green coffee bean extract, blueberry extract, chokeberry extract, bacopa supplementation, or CBD oil. The last one is probably the most expensive. But any one of those guys will work. Something exogenous that will help increase the production of brain-derived neurotrophic factor, which is a hormone that pushes the brain cell to make more connections, okay? Now, number 3, phosphatidylserine, at least 300 milligrams a day. What is phosphatidylserine? Okay. Now, think about at the top rectangle, you see those brain cells, and notice that you don't see a lot of connections there. At the bottom rectangle, you see a lot more. If we were to look at a close-up of the plasma membrane of the brain cell, you'll see that the plasma membrane of a brain cell is made up of 4 lipids predominantly, okay? One lipid you see in that lipid bilayer is cholesterol. Notice that it's circled in tan, okay? So cholesterol, that comes from animal fat. No problem getting that in the American diet, right? Next, phosphatidylcholine. Another name for phosphatidylcholine is lecithin. That is rich in many normal foods that Americans eat. So we're not low on that. Next one, phosphatidylinositol. Just like lecithin, there's plenty of it in the American diet. Now the last one, phosphatidylserine, I've circled in orange, and it's bold. That's a big deal because there isn't a lot of it in the American diet. Americans don't eat foods like we used to that are rich in phosphatidylserine. So that means most of us are deficient in phosphatidylserine. But why is that a big deal? Well, phosphatidylserine, if you don't have enough of it, you won't make synapses. If you're low on any one of these guys, synaptogenesis will stop. And for Americans, the thing that we're lowest on is phosphatidylserine. What are naturally occurring foods that have phosphatidylserine? Well, if you Google it, if you go to Wikipedia, this is the list that they will show you. Number 1, bovine brains, cow brains. Who eats cow brains? It's like, you consider that an actual food? In other countries, I guess they eat cow brains. In the United States, I've been in the United States for over 60 years, and not one time has somebody invited me over for dinner to a big pile of cow brains. I mean, it's just not something that anybody ever did. I don't know anybody that eats cow brains, to be honest. So why they would list that as a food is beyond me. You know, it's like, well, cow brains contain 100 grams of cow brain has 713 milligrams of phosphatidylserine. Well, yay, but not still. I don't find that very enticing. Okay, the next thing, organ meats such as liver and kidneys also contain high level of phosphatidylserine and are not a risk for mad cow disease. Well, yay. Okay, but again, you know, my mom actually used to eat those things, but we never did. I mean, she would cook them, and I tasted those chicken livers and stuff, and I was like, no, thank you. You know, but yeah, if you're into organs, then good for you, because that's a great source of phosphatidylserine. Now, white beans and soybeans, those are a source of phosphatidylserine, and that's why we're not all walking around and is spaced out all day, because that's, you know, some of us do eat those things. So those, but I don't know about on a regular basis, but at least we do have those in our diet occasionally. Okay. Now, small fish, our ancestors ate lots of small fish like sardines, smelt, and eel. Those are rich in phosphatidylserine. Our ancestors, especially those that were born before 1920, they used to eat a lot of sardines. And when they died off in the 70s and early 80s, people stopped eating copious amounts of sardines and mackerel and stuff like that. Okay? But those were sources of phosphatidylserine. The only American food that is eaten with regularity, especially with regard to meat, would be chicken legs and turkey legs. So, if 3 times a week you want to sit down to a meal of beans and chicken legs, then you're in luck. You probably don't have to supplement. But if you have a typical American diet where these things are not eaten very commonly, then you probably need to supplement. And I usually recommend phosphatidylserine for people with ADHD. I recommend it for people with age-related memory decline. That includes anybody over 55, okay? And also mothers, women who have a history of depression, who get pregnant. I put them on phosphatidylserine because you need to make a brain for that baby. And if you don't have enough phosphatidylserine in your diet, baby will get it from mom, and mom will get depressed afterwards, okay? So when I do TMS, what I'm trying to do is stimulate synapse production. And if they don't have enough phosphatidylserine, in spite of the fact that I'm zapping their brain trying to get those little dendrites to grow, it's not going to work very well. Because in spite of all my zapping, if they don't have phosphatidylserine, the procedure is not going to work very well. So I recommend go on phosphatidylserine, 300 milligrams a day. Take it throughout the procedure and even several months afterwards, because I have had situations where people didn't respond to the TMS until like a month later, and then their depression went away. So at least a couple months throughout the procedure, maybe 2 months thereafter, to stimulate neurite development, to stimulate the production of those dendrites, and therefore address the depression that way. Okay? So that's why the phosphatidylserine is recommended. So hopefully you have an understanding as to why I recommend the supplements that I do. Hopefully you have an understanding also of why why we exclude some people from the program. There's, you know, if they're going to be brought into the TMS program, we don't want them, again, taking a bunch of benzos. They need to be depressed enough. They need to have been tried on antidepressants plus an augmentation strategy and so forth. Okay? So, Lindy's has one more thing to add, I think, and then we'll open it up for questions.
Okay. Hi there. Can you let me share my screen, please, Dr. Guy?
Oh, yeah, sure. Let me stop mine. There we go. Boom. Okay.
Okay. Here we go. Sorry, bear with me here. Oh. Okay. So my role in this is I'm Dr. Guy in Perspectives TMS coordinator. And what that means to you is I am that bridge between your clients and his patients to TMS. Not only do I treat them, but because of the nature of this treatment, it's very long, it's extensive. What I do is I'm a communication for you. I give you feedback to you for what's going on with your patient. If your patient has questions, if you have questions, like Dr. Guy, when he mentioned some of the criteria insurance-wise, that's a lot to remember, and every insurance is different. That's what I'm here for. So these are kind of the ways that I can help you out when you're determining if a patient is a good match for TMS. I'm available to answer questions, give information for yourself and for patients. I provide any kind of consultation, whether it's with you or with a patient or patient's family. I'm here Monday through Friday in the office, but if somebody wants to do it virtually, I can do that as well, or through the phone. I can help determine, like he was talking about the contraindications, some of those things, I can help determine the basic ones. They always do go on to see Dr. Guy for an actual psychiatric evaluation, but I can rule out some of those things that you may not think of or remember, or the patient may not think is important to tell you. Like he said, there's no non-removable metal, like no cochlear ear implants, anything like that. That would definitely disqualify somebody. But there's other things that we can kind of work around, certain situations that might be an exception. I can help with that. Also, we all know that insurance is a very tricky animal, and it's kind of a pain in the butt to deal with. Your patients and you don't really need to worry about that. I will get any prior authorization handled. I may get some information from them, some history, but I'm available to get all the prior authorizations that are needed. And one thing he did mention about the trials, that is very accurate, that most insurances require like 4 trials, augmented treatments. The only insurance that is so easy, he mentioned Medicare. Medicare only requires 1 trial of failure on an antidepressant. They don't require any augmented treatments. They don't require any prior authorization. They're very easy insurance to deal with when it comes to TMS. But again, these are all those kind of things that maybe you don't remember and you're not sure about before you want to make that referral. Just reach out to me and I can help you make that determination, or I can check on it for the patient. A lot of patients want to know, what are my costs going to be? What is it going to look like for me when I actually do this? That is where I come into play, and I take a lot of that pressure off of you and off of them. Okay, so I will also then, if they move on to the phase where they would like to schedule Dr. Guy, I will make arrangements to schedule for that evaluation. And then once going forward from that, then I will schedule all their TMS appointments with myself, and we'll work out a schedule that works for the patient. And again, I'm always available to for you, if to let you know how somebody's doing, if you have any questions. I'm a good bridge between that, because we don't want to necessarily stop therapy. We want them to do better in therapy, be able to do the work, just like a medication might work for somebody. So we'll continue working together while they're doing therapy and TMS if they're in active therapy with you. So this is my contact information. Again, I'm in Troy. I'm at there. If you come into the office, which some of you I don't see so often, but if you start coming in all the hallway, all the way to the back, I'm at the very end. So if you don't hear the machine running, you can knock on my door, and if you have a question, or you can email me, or you can call me. You can just give your information to a patient and let them know. Contact Lindy. I'm happy to call anybody, or like I said, do any kind of virtual appointment or phone call, whatever a patient is comfortable with. That is going forward. So I'm going to ask, does anybody have any questions for me directly, not necessarily about the procedure, but about how getting your patient a referral?
I have a question that might apply to both of you, actually.
Okay.
This is just out of curiosity. I know, Dr. Guy, you mentioned phosphatidylserine for age-related memory decline. I was curious if TMS is approved for age-related memory decline or Alzheimer's or dementia.
Not at this time. Those are trials that are ongoing, but not at this time. We'll see what happens in the next, I think the next 10 years will be exciting, but those things are being looked at.
There's a lot of things being studied right now, like autism. There's a lot of things they're working on right now with TMS.
Yeah, as functional neuroimaging is revealing, where I mean, this is an exploding field. Psychiatry was virtually unscientific until the 90s. And with functional neuroimaging and the Human Genome Project, I mean, every year the amount of new information about the brain is astounding. I mean, nobody can keep up with it. There's so much. And TMS is way behind in terms of now that we learn where in the brain all these circuits are we have this tool to stimulate those and to manipulate them for specific outcomes regarding mental health. This is awesome, but it's going to take time to get all these approvals. So there's a lot in the pipeline. So we'll see what the future holds.
Oh, cool. I just have one other question,
Sure.
if I may? And by the way, awesome presentation, very informative, really, really great. Are there any nootropics or cognitive, like herbal cognitive enhancement type supplements that would be contraindicated besides, well, just in general? I know there's a really popular one called Qualia that has different things in it. It's a stack. So would any of those neurotropic stacks be contraindicated?
They wouldn't be contraindicated. I just that when people talk about nootropics, usually, I if it works, it works. It's just that when you allow people to put agents together, they charge a premium, and they're so expensive. Whereas if you would take the principal agents that have, I mean, there's some good stuff out there that really do help with cognition a lot. If you just take the dose that was used in the clinical trial, you get the benefits. What many of these companies do is they take a little bit of this and a little bit of that. Like, let's take a little bit of phosphatidylserine, let's mix it with something else like cat's claw, and then let's throw a little bit of vinpocetine, and voila. Now, each of these have tremendously beneficial effects on memory. But when you put them together in those tiny doses, now it might not do anything. And if you do get benefit, it's usually psychosomatic. But they're charging you 10 times what you would have spent if you'd taken them independently. So a lot of times, these people they read the literature, get excited, throw a bunch of things together in one pill, and then charge you 50 times what it cost them to put them together. And so that's why a lot of this stuff I don't recommend for that reason.